Hello. A very good afternoon to one and all. On behalf of IDA Chandigarh chapter, I welcome all the participants, our NEC member, Mrs. Madhu Sharma, as well as members of local executive committee of IDA Chandigarh chapter. The topic of today's webinar is FODMAP-Diet-Indian-Perspective. As you all know, FODMAP is an acronym for fermentable, oligosaccharides, disaccharides, monosaccharides, and polyols. This was developed to describe these poorly absorbed short-chain carbohydrates. While some people are able to consume FODMAP diets without experiencing any gastrointestinal side effects, but many people with digestive disorders, as in irritable bowel syndrome, they often find that FODMAP triggers symptoms like abdominal pain, cramping, bloating, excess gas, constipation, and sometimes diarrhea. So the reduction of FODMAPs in patients' diet may help to improve functional gastrointestinal symptoms and also used for treatment of IBS patients. The prevalence of IBS varies from 4 to 20% in different Asian nations, whereas in India, it varies from 4.2 to 7.5%. So IBS is a chronic and relapsing disease, and symptoms often wax and wane, and the symptoms also varies between different individuals. There are many questions in mind: what food should we eat? What foods to avoid? Can I drink milk? Can we have this fruit? Or which food produces gas? So to answer all the questions and queries, to clear our doubts, today we have with us our eminent and very dynamic speaker, Dr. Jagmeet Madan, who is the epitome of knowledge in the field of nutrition. In addition to shouldering her responsibilities as principal and professor of SVT College of Home Science, SNDT University, she is also the national president of Indian Dietetic Association. Can we show ma'am's slide, please? Dr. Madan does not need any introduction due to her excellence in academics as well as in professional field. But just to brief and to know her more, she is a gold medalist and recipient of Young Scientist Award, Dr. Ramanathan Award by the Nutrition Society of India. She is also the recipient of prestigious International Research Grant Award, PNPG grant from American Academy of Nutrition and Dietetics, USA. She was also awarded Maharishi Karwal Utkrisht Shikshak Award 2017 by the SNDT University, Mumbai. Next, please. Next slide, please. Can we have the next slide, please?
Just a minute, ma'am.
Okay. Ma'am is also the lead principal investigator of international research project on pre-diabetes in adolescents and young adults in India and food-based intervention approved by USDA 2018 to 2020. Urban Nutrition Gap Study in Mumbai from 2015 to 2018, Project Mark 2008 to 2010, a multi-centering pan-India project on school-going children, government as well as private schools, in collaboration with Diabetes Foundation of India and World Diabetes Foundation. She is also associated with Tanita Health Link Project with Ministry of Japan from 2014 to 2015. Ma'am was the mission leader of Joint Review Mission of Ministry of HRD Government of India for the evaluation of midday meal program in state of Maharashtra from 2012 to 2013. Dr. Jagmeet is also an expert on the FOSAI scientific panels on labeling and claims, advertisements, and scientific panel of nutrition and fortification from 1st January 20 to 31st December 2022. She is also the member of National Steering Committee of NetProfan FOSAI, a Government of India project. Ma'am is a certified master trainer of Project Hope, a diabetic educator project in India by International Diabetic Federation. She is the author of Indian Manual. She is also the part of National Expert Working Committee on Asian and Indian Consensus Statements and Guidelines on Obesity, Diabetes, Cardiovascular Diseases, and Physical Activity and Gut Health. She has more than 50 publications in international and national peer-reviewed journals as well as books. She is a regular columnist in Times of India, Midday, Mumbai Mirror, Wellbeing, and Femina. So I welcome Dr. Jagmeet ma'am. Thanks ma'am for sparing your valuable time for this webinar. So over to you ma'am, please.
Okay. So a very, very good afternoon to everyone. At the outset, very warm greetings from on behalf of Indian Dietetic Association. You will not believe how happy I was to accept this invitation, because I've been talking to Sunita for such a long time, and I committed and I said I'll definitely talk to IDA Chandigarh chapter specifically, and we'll try and do it during Nutrition Month. And Sunita is another dynamic convener of IDA Chandigarh chapter, and she in turn collaborated with the IDA NSI chapter and NetProFan stakeholders. So I think she really expanded the reach. And so thank you very, very much for inviting me. And I'm really privileged to be here. She asked me this question that, why do you take up such varied topics? So my answer to that is that I take this as an opportunity to push myself to read more in that area. So friends, what I'm going to share with you is actually the review of what I could analyze and I could understand what is latest in the field of FODMAP. And why I also took this topic was because I really feel that, there is a felt need for today's nutritionist to really focus on this area. And when I was reviewing, the literature, and I was trying to understand what are the possible, areas or lacunas which I could identify, and I really felt that, handling an IBS patient with FODMAP diets is a really skilled job of a nutritionist, and to become skilled, you really need very good training. Not only training, you also need very good validated tools. And in India, when I was reviewing literature, we have very less Indian data, right? So what we have is all Western data, and I'm very proud to share today that in this tenure, IDA took the lead to collaborate with Monash University, Melbourne, Australia, who are the pioneers in FODMAP. And again, I'm very happy to share that we are collaborating with them to do some preliminary research this year, and take the research questions forward and see how we can contribute to the lacuna in the Indian data, right? So I'll take you through a journey which may start from basics to the algorithms which are standardized and followed. And also I will touch upon the Monash template, what they have developed. So, so basically we are all friends learning together. And so let's do this another 25 to 30 minutes of reviewing of this area. So give me a minute, let me share the screen with you. You can see my screen?
Yes, ma'am.
You can see my screen?
Yes, ma'am.
Okay, thank you.
Yes, ma'am.
Yeah, and you can hear me clearly?
Yes, ma'am.
Okay, so do interrupt me if you find difficulty in looking at my slides, or you can't hear me at any point in time. So I'm going to look at FODMAP diets and try to reason out an Indian perspective of what is available. So when we start the conversation on FODMAP, I think the first keyword which we all need to address is the irritable bowel syndrome. So irritable bowel syndrome, I'm sure all of us know, it's a common chronic gastrointestinal condition. So it's chronic, it's not acute, it's always develops over a period of time, and it is characterized by disturbances in bowel habits, abdominal pain, in the absence of known organic pathology. I think that's a very important phrase, that we still don't know what exactly causes irritable bowel syndrome. But we have a standardized diagnostic criteria, which is the Rome 3 latest diagnostic criteria, which clearly indicates that if we have symptoms present for the last 3 months, with the onset of the symptoms in the last 6 months prior to diagnosis, and what is highlighted is that in the last 3 months, if the recurrent abdominal pain or discomfort is associated with 2 or more of the following, that is improvement with defecation, or onset associated with a change in frequency of the stool, or onset associated with a change in the form of stool. So we use Rome 3 diagnostic criteria for irritable bowel syndrome, but what are the red flags that require further testing and you need a specialist assistance? So the red flag indicators are definitely if you are seeing these symptoms above the age of 50 years, with no previous colon cancer screening. So, some of these things are a red flag. You really need to encourage the patient to go for further assessment. If there is overt gastrointestinal bleeding or a recent change in the bowel habit, or there is nocturnal pain or, passage of stools, or unintentional weight loss, so, or palpable abdominal mass, or fecal occult blood. So these are all the red flags which should really bother you, and you should encourage the patient to go for specialized assessment. Now, Sunita did speak about the prevalence of IBS, and I feel as Indians we are blessed because the prevalence of IBS as compared to Western countries is definitely lower in Asian countries. So in the United States, nearly 20% of the general population is known to be affected by IBS. And you must have heard a lot of people from US talk of colonoscopy, and they're worried about their, colon so much because of the dietary habits they have. The meta-analysis shows a pooled estimate of international IBS prevalence of 11.2%, with a variation by geographic region. So the lowest is in South Asia, 7%, and the highest is in South America, which is 21%. The usual age group would be 15 to 50 years, and the prevalence of IBS in general population of India, though I'm not in the know-how of very many studies. There are very few studies, but the latest study which I could get hold of was by Nagaonkar et al. And the IBS prevalence in general population of India is 15%. So pathogenesis of IBS is multifactorial. Okay, so that's why I said right in the beginning that you really cannot pinpoint and say this has caused IBS. So whether it is your genetic polymorphism, your inflammatory markers which are getting predominant, working at the cellular receptor level, at the gene expression level, is it stress, which is getting precipitated by anxiety, depression? Is it mucosal permeability, which gets again impacted by the kind of gut microflora which you carry? Is it mucosal immune activation? Or is it food hypersensitivity, bile acid malabsorption? Or is it transient infection which has led to altered and unstable microbiota? Or is it, altered endocrine metabolism? So it's very difficult to pinpoint one finger and say that this led to IBS. In a patient, you will always find a blend of factors. Something can be more, something can be less. So when you look at the subtypes of IBS, there are 4 subtypes. So you have IBS-D, which is characterized by diarrhea. So you have loose or watery stool more than 25%. You have IBS-C, that is constipation, so more than 25% hard or lumpy stool. Or IBS-M, which is a mix of diarrhea and constipation. And IBS-U, where abnormality of stool consistency is insufficient to meet either, C, D, or M. Okay. So what are the treatment modalities? It clearly indicates that you really need to document the case history of the patient very, very precisely. And that's where I feel we should have an Indian validated tool for documenting the case history of IBS patients in India, because you are looking at so many factors in that. You're looking at their exercise habits, you're looking at their dietary habits, you're looking at what kind of prognosis the patient had, what were the treatment modalities, what were the dietary alterations done, was the patient satisfied, okay, what were the effects? So this is the entire protocol which you need to follow when you are looking at the IBS patient. Now the algorithm for dietary management, which is spelled out by McKenzie, which is the latest which I could lay my hands on, and it clearly indicates that the first line is not FODMAP for IBS. The first line is the complete clinical and dietary assessment. When you say clinical and dietary assessment, you are checking the eating behavior, you're checking the lifestyle, physical exercise, clinical symptoms, family history, allergies, food intolerance, medications, BMI. You're looking at 5 factors like dietary fiber, fatty food, caffeine, spicy food, alcohol. So if you can get a complete detailed case history and you can modify some of these dietary and lifestyle factors, to a certain extent, and if you see that there is adequate symptom relief in the patient, so then this becomes your long-term management, right? But if we are not getting any success just by this initial detailed assessment and intervention, that's when we would put the patient on a low FODMAP diet. And low FODMAP diet, I'm going to explain it further, would have foods which are having low content of FODMAP. And if by subjecting to this kind of a diet, you get adequate symptom relief, then you go one step further and you adapt the low FODMAP diet. Because remember, everywhere it is documented that a FODMAP diet should not be used for more than 2 to 6 weeks. And beyond that, you really need to graduate your patient to an adapted low FODMAP diet and then to a personalized FODMAP diet, right? So we go this pathway if FODMAP is agreeing with us, and that becomes our long-term management. But if after introducing the low FODMAP diet, still you're not getting any relief in the symptoms, that's when you really need to check beyond IBS and check diagnosis. Okay. So I hope I've made this algorithm very, very clear, because this is very, very important for a nutritionist to understand what is the chronological order in which I need to address the concerns of my IBS patient. Now, just give me a minute. I think just getting stuck here. Okay. So what is FODMAP? Sunita already explained to you that FODMAP stands for fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. So what are they? They are basically group of carbohydrates which contain about 1 to 10 sugars that are poorly absorbed in the small intestine, and subsequently they get fermented in the small or large intestine, right? So they can be found in very common and different foods. So it could be some fruits, vegetables, legumes, cereals, honey, milk and dairy products, and sweeteners. Now, all FODMAPs are potential triggers. So all FODMAPs definitely trigger symptoms, but not all FODMAPs exacerbate abdominal symptoms in the same IBS patient. That means all FODMAPs are potential triggers for sure, but not necessarily that all FODMAP food would, give those kind of symptoms in the same IBS patient. So each IBS patient may have a different tolerance to the FODMAP foods. Now, the total daily intake of FODMAP in a habitual diet ranges from 15 grams to 30 grams per day. And what we also find is that the low FODMAP approach is not simply an elimination diet. It's not only an avoidance diet, it is a diagnostic tool test to test the patient's tolerance to some foods, so that you are actually in a position to customize the diet to the patient's tolerance. You are exactly in a position to identify what is it that your patient is completely intolerant to, what is it that the patient can tolerate in a certain quantity, and what is it that the patient is very comfortable with, right? So it is not only an elimination diet, but it is a diet which really helps you to customize patients' tolerance to a certain specific category of foods. Okay. Now, so when we look at the mechanism of action as to what exactly, these FODMAP foods are doing, they are actually, working on the osmotic activity of the small intestine and the large intestine, right? So osmotic activity, what does osmosis mean? That, it is a shift of fluid from low to high concentration. So there is a, influx of water in the small bowel, and you may, have hypersensitivity, diarrhea, or you may have increased production of gas or excessive production of short chain fatty acids, which is more predominant in the large intestine. So as a whole, the mechanism of action of the, these FODMAP foods relate to the visceral hypersensitivity, which is very, very typical of an IBS patient, and it may provoke abdominal pain, bloating, flatulence, and alterations in bowel habits. Okay, so if we look at the action of individuals' FODMAP subgroup, so the first important group is fructans and galacto-oligosaccharides. So they are not digested in small intestine, they are taken to the large intestine, they cause gas production, distension, bloating, abdominal pain, discomfort, and altered bowel habit. So the next category is your sorbitol, mannitol, and fructose, which are obviously fitting into the category of your sweeteners, your nutritive sweeteners. And when you see that, they also get absorbed slowly along the length of the small intestine, they add to the osmotic effect, cause distension and symptoms of pain and diarrhea. If they get incompletely absorbed, they may be pushed into the large intestine, and then in the large intestine, they can add to the bloating, abdominal pain, discomfort, and altered bowel habit. Now, lactose, for sure, that gets related to lactase deficiency, and lactose, when it reaches the large intestine undigested, would favor fermentation, bloating, wind, pain, and diarrhea. So, if we look at the Monash model, what they have done is they have categorized the FODMAP foods into a traffic light signal kind of a format. So you have the red category, which is like very high FODMAP content. You have the amber, which is like moderate, and you have the green, which is low FODMAP foods. So what we find is that for every food group, there is a type of, set of foods which fit into the low FODMAP alternative. So whether it is meat, poultry, seafood, and eggs, so you have the plain cooked meats, poultry, and eggs, which fit in. Whether it is a fruit, so you have the oranges, grapes, strawberries, cantaloupe, which fit into low FODMAP. And let me tell you that Monash has the largest database of FODMAP content of food. And I think, they have actually analyzed this content in their laboratories. And it's a very, very high standard data, which is recognized worldwide, right? So you look at all the categories, you have the foods which will, so say for example, dairy, you have all the lactose-free options over there, or substitute to lactose, whether it's soy milk or almond milk. So, this is a kind of list which is there to say that, what can you incorporate from each category and how many serves can you take per day. So whether it is fruit, it's at least 2 serves, and the choice is given over here. If you have vegetables, you have 5 to 7. Again, the choice is given here. The quantity is given over here. You have the milk. I already told you the options are again lactose-free milk, lactose-free yogurt. And for fats and oils, it's clearly indicated that you have to limit these foods. And then for meat, fish, poultry, again, you are clearly indicated what is it that you can have, how much can you have. And when it comes to cereal, it is again gluten-free, low FODMAP foods, or the breads, more emphasis on rice, again pasta, which is gluten-free, or rice noodles, or cooked quinoa. So these are all the options which are given for low FODMAP diets. Now, what are the phases of FODMAP diet? So like I said very clearly that low FODMAP diet, there are concerns of nutritional adequacy. There are many other concerns which I will share, which become a limitation for this diet not to be followed beyond a certain time, just like how you introduce it, right? So when you introduce a low FODMAP diet, the duration very clearly stipulated is 2 to 6 weeks, okay? So you basically swap the high and moderate FODMAP foods with low FODMAP alternatives. And I already told you that Monash FODMAP app, it's very readily available in Apple Store, in Google Play. You can download that app and it clearly indicates which are the foods which are high FODMAP, which are the ones which are moderate, and which are the ones which are low. Okay, so in this phase, you basically swap all low FODMAP alternatives into the diet of the patient. And what you do is that after you subject the patient to a low FODMAP diet step or phase, you observe the symptom relief in the patient. And if there is a significant relief in the symptoms, then you graduate the patient to a phase 2, wherein you do the FODMAP reintroduction. That means all the foods which you were, categorizing into the moderate category, you would try to introduce them in smaller quantity and see the tolerance of the patient. So it's a staged food challenges, and again identifying and recording the symptoms to these challenges as you do it gradually. And then the phase 3 is that, from supposing in phase 2, when you're doing this, the patient is again responding to this gradual introduction of certain foods, and for sure this is an absolute no-no. This can be, introduced in smaller, or can be tolerated in smaller quantity, and this is something which the patient is very comfortable with. So then finally in this phase 3, this is what you're going to do. You're going to actually make the FODMAP personalized. So FODMAP personalization happens in phase 3, where you liberalize the restriction, and this is the kind of diet which you want to recommend for a long term. Okay, so this, when you reach this stage, you clearly know which are the FODMAPs. Like I made a statement that all FODMAP foods may not bother all IBS patients to the same extent. So by the time you reach the phase 3, you know that this patient can tolerate these foods very comfortably, these foods in smaller quantities, and these foods can be completely eliminated. So if you draw a graph, you would see that a FODMAP flow would be bringing the patient from a usual diet to a phase 1 of FODMAP restriction, a phase 2 of reintroduction, and a phase 3 of personalization. Okay, now to what extent you determine the restriction again depends on where your patient is, because your patient is not this. It's not a typical IBS patient whom you are addressing. Your patient can have moderate to severe symptoms. Your patient can have mild symptoms and also can be one who's unlikely to comply with strict diet. Or, you may have an IBS in at-risk population, maybe an older adult, pediatrics, okay, where the over-restriction has to be avoided. Or you may have IBS in patients who are highly anxious, okay, or you may have IBS with contraindications to dietary therapy, especially the patients with eating disorders. So there are different levels of restriction for FODMAP diets, and every category has a defined algorithm to follow. Like what we till now discussed was the first category, where a typical IBS patient with moderate to severe symptoms taken to strict low FODMAP, adequate response, FODMAP reintroduction, and personalized FODMAP diet. But if there is a patient who cannot comply with strict diet or is at risk population, then you have to simplify the low FODMAP diet, because you can't make it too restrictive. And again, you have to see whether you're getting adequate response, inadequate response. If it is inadequate response, then you have to abandon this diet and you have to look at other dietary therapy. So you have to look at fiber, you have to look at specific triggers, which are making the patient uncomfortable, right? And if the patient is highly anxious, then again, you have to have an expanding low FODMAP diet, and you may be very precise in, kind of giving very less, restrictions, and then you gauge whether the patient is really gaining from adequate response. And for the patients wherein there are eating disorders, I think your whole approach has to be beyond FODMAP. So you really have to assess and ensure the nutritional adequacy. That becomes a priority, and you may refer on to non-diet therapies, whether it is pharmacotherapy or cognitive behavioral therapy or gut-directed hypnotherapy. These are all getting standardized therapies for IBS with contraindication to dietary therapy, and especially because these patients show a history of eating disorders. Now, so that is precisely, so there is so much of detailing in terms of the algorithm, the preciseness of the algorithm to be followed for an IBS patient. So my question to the nutritionists who are listening to me is that your expertise, your competence is first to identify where your patient is, here, 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 or here. If you are right here, then you will be also right and precise in following the algorithm which you should follow for a patient, right? So that is where I said that nutritionists need to develop very standardized, validated tools to discriminate between these categories. One. Two, they really need to be very precise in documentation and with very much, precise, crisp clarity. They should be in a position to do their diagnosis, do their prognosis, and follow the algorithm as I just discussed. The next aspect, which is very important in FODMAP diets, is checking the food labels. In India, of course, we are still I would say we are still reaching a stage that we are getting on to good labeling. I think I have my own institution, my own PhD student who worked on food labeling, and it came out very clearly that people do not read labels, they don't understand labels, but people who have nutrition background understood label more. It came out very clearly, and it also came out very clearly that people who have family members suffering from a disease, whether it's an NCD or any specific disease, are more conscious when they're looking at the label. So looking at FODMAP ingredient is another area which needs to be developed in food labeling, and you need to really educate. And in our research also, it came out very clearly that you really need to educate the patient, the people at large. And we did work with the young adults and older adults, and we found that a very precise education intervention. We actually developed a module for education and validated it, and we found that with education, you can get the desired outcome in terms of reading the food labels correctly. So to my mind, it's not only making the food labels complete, making them user friendly, but I think as nutritionists, we have a lot of onus of educating not only our patients, our family, our peers, our society to understand what is the significance of reading food labels and how to read how to read correctly the food label and what is the kind of information you should pick from, right? So today, FSSAI is concentrating on HFSS foods because that's a priority to us. We want people to identify which are the HFSS foods so they can cut down on their intake. Similarly, when we talk of high FODMAP ingredients, we really need to know the ingredient list which we need to look at. We need to look at the food processing, the serving size, okay? And if you go one step further, I think the Monash module gives you beautifully, the checklist of ingredients for food labels. So, you should look for fructose. And how would fructose read in your food label? It would read as fructose or high fructose corn syrup or honey or fruit juice concentrate or fruit pieces if that's the main ingredient, or crystalline fructose or agave syrup or fruit sugar or dried fruit. So there's so many things, so many ways in which you can identify a FODMAP ingredient on the label. Similarly, you have the list for polyols, you have the list for fructans. So we need to educate ourselves in terms of reading the labels correctly. And what happens when you are eating a food, which probably you feel is a FODMAP, but you don't know the content. So what is a step one? If you have consumed a food like that, wait until symptoms are well controlled. Step two, on day one, include a small amount, maybe 1/3 of what you consumed. And over 3 consecutive days, monitor symptoms response and adjust the serving size, frequency to find a personal level of tolerance. So finally, you will know, can you tolerate the food? If yes, safe to include. If no, avoid for now and then try again in the future. So we are in the process of, adding to the database of FODMAP, and that's where again our collaboration is going to be coming in, where we want to look at a variety of Indian foods and their FODMAP content and add to the database of Monash and see that how we can customize that app in an Indian environment. Now, there is also a mention about low FODMAP cooking, and it clearly indicates that cooking methods like boiling, straining, canning, soaking, and pressing, they help in eliminating the active components which are related to the abdominal discomfort. And similarly, fermentation is also indicated as a method which helps, but the traditional methods and a long fermentation time. But there is a mention about avoiding fermented foods like sauerkraut, which is high in mannitol. But of course, this is not so common, not so commonly consumed in India. Pickling, activation, and sprouting. I think this is also valued in terms of reducing the FODMAP content. And, so there is a list of a high FODMAP ingredient, how through cooking, through that treatment, we can convert it into a low FODMAP ingredient. So say, for example, garlic, the garlic is, of course, a high FODMAP ingredient. But how do we substitute garlic? We can use spring onion, but the green tips of spring onion. Or if you have to use garlic, we infuse it in the oil. Or if there is, wheat-based products, we substitute with the rice-based products. Similarly, when we're looking at beans and peas, they are talking about canned lentils, canned chickpeas. Of course, this is all, like I said, we need to customize some of this to our Indian environment, because what we see here is pretty much true to a Western environment, but something like this can definitely be prepared for an Indian environment, right? So how do you assess response? Okay, so on a scale of 0 to 100, if you are putting your patient, IBS patient, on a low FODMAP diet, you may have somebody who has no change in symptoms at all, you may have somebody who's midway, or you may have somebody who has total symptom relief. Okay, so depending on where your patient is, you need to keep customizing the diet. And I've already explained to you, you may begin with low FODMAP. You will, go to a phase where you will emphasize the reintroduction, and then you will go on to the personalized phase of FODMAP diets. So the risk associated with FODMAPs is it's complex and difficult to teach and to learn. So let's face it. I mean, I have interacted with a lot of IBS patients, and I know that most of them, you know, are very, very anxious. They're very much, you know, like they are actually scared that if they eat something, something will happen. Or, you know, they develop certain, what should I say, you know, prejudged convictions that, you know, if I eat this, this is going to happen. So as much as it is difficult for a nutritionist to analyze, to document, come to the precise prescription, it's also the same for a patient who is having IBS. So it's complex and difficult to teach and to learn. Very difficult to sustain because it becomes restrictive. And then when you're doing the fine tuning, you've got to be very, again, accurate in terms of what you include, how much you include, when do you eat. And sometimes if the options are pretty much that you have to be dependent on expensive option, the diet may become expensive. Then there is also a talk about, you know, a reduction of natural prebiotics and effect of this kind of diet on gut microbiota. In fact, whatever papers I read, I did find that this is one area which is getting explored now, that is it really impacting our gut microbiota, this kind of diet. Then, of course, it can lead to constipation, nutritional inadequacy, and eating disorder behavior. This is another area which is taking a lot of limelight now in relation to FODMAP and the long-term efficacy. So friends, finally, I would say that when we talk of FODMAP diets, when we talk of IBS patients, I think it is not only the registered dietitian or a nutritionist who is the game changer. You have to have the entire team in sync. So you have to have a team approach. You have to have your general physician, because that's your first point of contact with the patient, your gastroenterologist, your psychologist and counselor, your fitness expert, yoga trainer, because this again is very strongly documented in improving the symptoms in IBS patients using FODMAP diet. So what are the future perspectives? We still have to test the long-term efficacy. We need a lot of data on the FODMAP content of our Indian foods, the effect of cooking on the FODMAP content. What are the options which we can give to our Indian population? And I'm sure we as an institution, I'm going to contribute to this space for sure. Better food labeling, yes, this is another area where we can contribute. How is it that we can make labels more user-friendly and improve available knowledge and awareness? So my appeal to each one of you is that please refer to credible sources. And I think I'm going to make another request that if I can get through the conveners or from the entire nutrition fraternity, the individuals who are interested in doing the FODMAP course from Monash University, please do send in mails to me and to the NEC through your chapter conveners. Okay, if we know that there is a sizable number of people who are interested to undergo the training, we can liaise with them and we can see what best we can offer for you to get trained. Seek only professional advice from a qualified nutritionist to avoid unnecessary restriction. That's where I said, this is one area, friends, you really can buck up and get yourself trained and become a specialist. And of course, the low FODMAP diets application is not only in IBS, but you know, the implications can also be on the other functional GI disorders, which need to be investigated. So thank you very much for a very patient hearing, and I hope I'm in a position to give you, you know, some food for thought, some you know, leads which motivates you to dwell on this area more, and I'll be very happy to answer any questions. if there are.
Thank you. Thank you so much, ma'am. Thank you so much for such an elaborate, enlightening, knowledgeable. I think you have covered, you have explained it so nicely, each and every aspect. So whether it's diagnosis, whether it's labeling, food labeling, reading of food labels, I mean, all the things have been cleared, I mean, very well explained. So thank you to you, all, also other members, all the participants also. So I think there are 3-4 questions which I need to ask, ma'am.
Yes.
So there is one question from Mr. Manjeet Gill. His question is curd good to eat in summer? When to eat and how to eat?
Okay.
He is also the member of our
NetProFan.
NetProFan. Yes, ma'am. Yes, ma'am.
Welcome, Mr. Gill. So nice that you were listening to me, and I'm so privileged that you could hear my talk. So, Mr. Gill, you are talking in general about curd, or in relation to a FODMAP diet? I think he's talking in general.
Yes, yeah, ma'am. General.
So the question is that, what is the question? Can you repeat, Sunita?
Yes, ma'am. He has asked, is curd good to eat in summer? When to eat and how to eat?
Okay. So let me go step by step. First of all, if you ask me, among the milk and milk products, which is the best milk product which we recommend, it is the curd. Okay. Because remember, we value milk and milk products for certain nutrients, which we cannot get so readily and so in a form which can be easily utilized by the body. And one nutrient is calcium, right? And some of the B complex vitamins. We also value milk and milk products for vitamin D, but calcium for sure. But the moment milk gets converted to curd, there is formation of lactic acid. So there is a change in the pH, and the availability of calcium is tremendously improved. Secondly, in India, we do find a lot of people who are lactose intolerant, right? They may not tolerate milk per se, but if you give them curd, they are in a position to tolerate, right?
Yes,
so definitely, according to me, you can consume curd in any season, whether it is winter, summer, rainy, any season, because as nutritionists, as scientists, we go by the science. Yes. There could be body types, there could be body composition, and you say that, oh, I had curd and my joints are aching, or we connect using curd at night with the sore throat, or with the pains in the bones, but I as an individual, I'm talking from my personal experience, and I'm also talking on behalf of many of us, that we don't relate foods to such relationships which do not have any scientific validation.
Yes.
Right? So to my mind, we value curd as a food which is giving us a lot of good nutrients, right? So point number one, it should be consumed. Point number two, it can be consumed in any season. Okay. It can be consumed definitely with the meals, for sure, because it's a value addition. It's adding good quality protein to your plate. And we always say that protein is a very important nutrient in your plate. So with your dal, if you have a bowl of curd, you are doubling the effect of protein. So to my mind, you can consume curd in any season, at any time. Sometimes, because curd also has a low GI, so it also serves as a very good bedtime snack. And especially, pre-diabetics or, diabetics who take oral hypoglycemic drugs. Sometimes for bedtime snack also, we say that you can have, a small bowl of curd. Because it's giving protein and it has a low GI, right? and it has a defined amount of carbohydrate, which has a low spike in the sugars. So one has to reason out how you fit it in your in your matrix, your requirements. So I hope I've answered your question.
Yes, ma'am. It was very clearly defined, very clearly answered. Ma'am, there is one more question. Can prebiotics be provided by altering the FODMAP diet? So there is a question from Miss Ruhi Garewal.
Yeah. See, if you see some of the the components of a FODMAP diet, they are actually very potent prebiotics.
Yes.
You look at oligosaccharides, you look at fructans, you look at, all these are ingredients, they are substrate to good microflora in the gut. Yeah. So when you are actually putting a patient on a very low FODMAP diet, that is where your concern is that, you should always keep a low FODMAP diet for a defined period of time, right? So that's why I said 2 to 6 weeks. You would not go beyond that. You would try to get the patient from low to a stage 2 where you're trying to incorporate other foods in different quantities. And no one individual is intolerant to all FODMAP foods, right? Because your levels of tolerance for different components will be different. So it's your intelligence that how you can maneuver your selection in such a manner that at the back of your mind, you should always be thinking that what are the prebiotic substrates you can pick and give to this patient so that it favors good microflora.
Yes, yes. Thank you, ma'am. Thank you. Ma'am, there is another question from Mrs. Shweta Batta. She has asked, how can we calculate total FODMAP content of a diet?
Yeah, so good question, Shweta. That's what I said that, Monash University, Melbourne, that's the world-renowned body which has come out with scientifically analyzed FODMAP content of variety of foods. And I had a interaction myself with Dr. Jane Moir, and she told me that, they've also analyzed a lot of Indian foods which are available in Melbourne. Yeah.
Yes.
So that's the database on which they have created this FODMAP app. Like I said, it's downloadable. You can have a look and see how they have quantified things. And it's basically for the usage of patients to kind of self-check as to what are the foods that they need to avoid, what is it that they can take in moderate amount, what are the low FODMAP content. So it's quantified, in the form of an app, but I don't think so that kind of data is available in public domain. At least I could not lay my hands on. Yeah. And in India, like I said, we are beginning to work in this area.
Yes,
so let's see what we achieve. Yeah.
Thank you, ma'am. Thank you so much. Ma'am, there is another question. Yes, Dr. Rama Goel. She is from Patiala. She has asked, in diabetic patients, can we reverse the diabetes only with gluten-free foods, as some dietitians say? If gluten-free diet is not given, then it cannot be reversed. So this is regarding...
Okay, so my opening sentence to this question would be, Doctor, there are no magical foods, there are no magical nutrients, okay, which can reverse or cure diabetes, okay? I think we as individuals need to understand, why do we get diabetes, okay? So if we know what exactly has precipitated diabetes in us, that is where we need to focus, and we need to kind of, customize or tailor our diet with the help of a nutrition professional to see that what is the quantity of carbohydrate you're taking, what is the quality of carbohydrate you're taking, how are you distributing your carbohydrate throughout your day. It's not that if you stop gluten, you're going to cure diabetes. No. The glycemic index or glycemic response of wheat as a cereal is definitely higher than rice. Okay, we've done some work on resistant starch, and we found that, you know, if even the resistant starch content of rice is higher than wheat. And when you cook rice, especially brown rice, you cook, you cool it, the resistant starch content increases. Okay. Similarly, when you dextrinize a starch, okay, so when you convert a roti into a paratha, not a a loaded paratha, but if you just dextrinize it with little fat, your resistant starch content improves. But at the end of the pulses, your pulses have the maximum resistant starch content. So what is important for a diabetic is, in any case, take a message from me that carbohydrate in the form of cereals is a rationed food for a diabetic. Okay, and we always show a healthy plate to a diabetic, and we say, look at your plate. Half of your plate should be filled with vegetables. Okay, and that half of vegetables, you know, should be in the form of salad, and the remaining half should be in the form of lightly cooked, local, seasonal, green colored vegetables. So half of your plate is vegetable. 1/4 is your good quality protein, which can be your katori of dal, which can be an egg, which can be a chicken, which can be paneer, which can be a curd bowl, and only 1/4 is your cereal, right? So whether you put brown rice in that, whether you put one chapati over there, whether you put half bhakri over there, you know, in totality, what you have to see is how are you making your plate, and how are you, maneuvering the glycemic response of your meal. And another thing, let me tell you, is another skill of controlling your sugars is, when you start eating, eat your fiber first. So eat your salad first, right? Eat your vegetables more, first, and then go on to your protein, and then go on to your cereal. So if you just change the order of your eating, so you make your plate well, you change the order of your eating, you take it from me, there is going to be a difference in the spike in your sugars, you know, post your meal.
Thank you. Thank you so much, ma'am. I think, Dr. Rama, you have got your answers from such an experienced person, and she has so nicely explained. Ma'am, can we take up 3-4 more questions if you have the time?
Sure.
Because everybody wants to interact with you and listen from you only. So there is one question from Dr. Nancy. She is one of dietitians in our department. She has asked, apple is a fruit which is prohibited in low FODMAP diet plan. Thus, peeling the apple makes it in the list of foods which can be eaten in a precise amount.
Yes, definitely. I mean, if you remove the peel, yes, I think the tolerance would be better.
Improved. Yes, ma'am. Yes, ma'am. So, Mr. Bera, you wanted to ask something?
Yes, one question from my side, ma'am. Maximum time I'm seeing.
Your voice is breaking, Mr. Bera.
I think just he's lost connectivity. I think. I think he's lost connectivity. Sunita, you can go on with the next question. I think we can get him later. Sunita, you're muted. I could not hear you. You're muted.
Okay. Ma'am, can I? Okay. So one person, Mr. Ashwin Pillai from Mumbai, he has asked, I am lactose intolerant, but I love milk a lot. So I consume. How to cut down milk to be healthy?
Okay. So Mr. what's his name?
Ashwin Pillai.
Okay, Mr. Pillai, if you are lactose intolerant, see, most of the people, they say they are lactose intolerant, but you need to ascertain, you know, what is your level of lactose intolerance, because lactose intolerance is very relative. You know, if you have an absolute lactose intolerance, that means you can't even tolerate even a speck of milk in any form. So you need to, test, like I was just explaining about FODMAP diet, that, you need to give your body a challenge. If you feel you are lactose intolerant, don't consume milk. Consume small amount of curd and see, does it bother you? Does it give you, gastrointestinal symptoms? So likewise, try different milk products. And sometimes, some of the lactose intolerant individuals tolerate milk in a cooked form better. Okay. So you need to, again, consult a nutritionist who can guide you as to what are the things which you can, use as a challenge to your body, and see, are you comfortable with them? And then if you supposing feel you're comfortable with curd, then again you can grade that challenge and identify for yourself, are you comfortable with one bowl of curds, and you can't go beyond that. So depending on where you are on a scale of 100, so far as your lactose intolerance is concerned, you need to tailor and customize your diet. And nowadays, you also have a lot of substitute to milk. You have soy milk, you have almond milk, So you can definitely look at those options. But remember, the moment you eliminate milk and milk products from your diet, then you again need professional help to tell you how to get your protein, how to get your calcium. Because when you eliminate something, then you must find ways how to substitute that in your
Yes,
diet. Okay. So these are very important messages which you should take with you.
Yes, ma'am. Truly. Mr. Bera, can we hear from you?
We have your question. We lost you because of your connectivity.
Yes,
Mr.
ma'am. There was an internet problem. That's why. So some patients were asking about that there is no symptoms regarding the consumption of the diet, but when
there is no symptom for
the IBS.
Okay.
When there is adequate diet, they are following their diet perfectly. But what else triggers to them for reoccurring the symptoms sometimes? That I mean to ask from you.
Yeah. So you asked a very good question, Mr. Bera. See, the thing is, right in the first slide, I said that to pinpoint and put your finger and said that this is causing IBS is very, very difficult.
Important.
Okay. So even if I get my food right, if I am having absolute planning for my food, there could be a stress, there could be anything else which can trigger my IBS. Okay. So that is where, I said that, when we are documenting the case, when we are taking the case history, we need to document all the etiological factors which can get related to IBS symptoms. And if, you are saying that the patient is following the diet, was getting a lot of comfort, and all of a sudden, the symptoms have got aggravated, then you again need to recall that what went wrong, under which etiological factor things went wrong, that, there was escalation of the symptoms. So it's very, very difficult to pinpoint and say that, this is the reason why it got escalated.
Yeah. Thank you, ma'am.
Yes, ma'am. We have got appreciation from so many participants, ma'am. And one of our students, she has been enrolled in the Monash FODMAP diet. She has written, "Thank you, ma'am, for this informative session. I am really thankful to Jagmeet ma'am and Sunita ma'am for providing students like me an opportunity to do a course from Monash University on FODMAP diets." And we have got so many appreciation words from maximum members.
Thank you so
Thank
much.
you so much, ma'am. Now, may I request Mr. Bera to convey a vote of thanks to ma'am and all the participants, please.
Thank you, ma'am. Good afternoon to everybody. A big to our National IDA President, Dr. Jagmeet ma'am, being with us. It has been a great honor and privilege for our Chandigarh chapter of IDA to thank you for being the expert and delivering an informative, thought-provoking lecture on FODMAP diet Indian perspective during this webinar. Ma'am, your august presence has facilitated the webinar to achieve its desired goal, objective, and outcomes. I believe the knowledge you have shared with us help immensely in the plan.
I think
Yeah, this.
I think his voice has again
No, I
breaked.
think he's having issues of the
Yeah,
Chandigarh chapter extend my heartiest salutation to your good self for sharing your valuable knowledge. Thank you very much, ma'am. I would like to extend my special thanks to our chapter convener, Malhotra ma'am, who always stands with us as a front leader for organizing this webinar, having an important and very informative topic for all the dietetic fraternity. Last but not the least, I would like to give my heartfelt thanks to all the attendees, our NSC member, Madhusama ma'am, and all the LEC members for their kind attention. Lastly, I really appreciate InBig Healthcare Private Limited for technically supporting this webinar, especially Mr. Pradeep Sharma and his entire supporting team. Thank you once again for your kind attention. Thank you, ma'am. Thank you all.
Thank you
once
Thank you for
again.
the opportunity.
Thank you,
Thank
ma'am.
you,
We
ma'am.
are indebted so nicely. So, I mean, you have really spared time for us. I'm really thankful to you, ma'am.
Thank you.
Thank
Thank
you.
you
Thank
so
you.
much.
Thank
Thank you, ma'am, for excellent lecture. Thank you, ma'am.
Thank you.